Good morning, everyone. Thanks for spending your morning with us. Chris and I are so appreciative of that for understanding the world of dementia. Just a reminder that this event is being recorded. Before we begin, I'd like to let you know a little bit about Elderwerks. We are a not-for-profit 501c3 corporation whose mission is to provide older adults, seniors, and families information, referrals, and guidance for senior living, home care, and support services to help make appropriate decisions. This includes education on senior topics for community members and professionals. The guidance we provide will help seniors stay home well or transition successfully. To earn CE credit, please make sure you stay through the entire hour, and the evaluation will pop up on the screen at the completion of the webinar. We'll email you the link to the form also, should you wish to complete it later. We are collecting evaluations a little bit differently, just to streamline this. If for any reason you're calling in or you can't complete the evaluation, in the chat I put events@elderwerks.org and our phone number 847-462-0885. If you have any questions throughout the presentation, please use the chat button and we will address those questions at the end of the presentation. Unless I find there's something important for Chris, then we'll go ahead and ask that. Reminder at the end, the evaluation will pop up on your screen, and we thank you for coming. I'd like to introduce Chris Petrik, our NBS, Director of Education, and our newly formed Dementia Reality as a Master Trainer.
Hi, everyone. Thank you for coming. Before I get started, I'm going to just change and get rid of these black boxes that are on your screen right now. You'll see a black box in the middle, but that'll go away. Actually, before I even finish the sentence, there we go. So we're going to talk about the world of dementia today and understanding it. So we're going to define what dementia, Alzheimer's disease, and Alzheimer's disease-related dementia. That's what the ADRD stands for, Alzheimer's disease-related dementias. What is normal versus non-normal aging, reversible types of dementia, irreversible types of dementia, brain changes with dementia, recognizing how dementia affects people differently, and understanding what meeting in their world means. An important consequence of aging of the American population is the significant increase in the number of older adults with some form of dementia. Perhaps two of the greatest challenges are distinguishing what normal aging is from mild cognitive impairment. And you can see what the MCI is here. That stands for mild cognitive impairment and or neurodegenerative disorder. And also to provide appropriate care and guidance for those persons being diagnosed with dementia, as well as their care partners. Major functions that help distinguish normal aging from your neurodegenerative diseases include the type and extent of cognitive impairments, memory loss, impairments in executive functioning. And that really is the particular, when we talk about executive functioning, the one that's really affected most is the ability to focus, concentrate, reason, and problem solve, as well as some sensory impairments or on one or more of the five senses. In normal aging, the body gradually slows down, but intelligence remains stable. Our bodies have less physical and mental flexibility, and it takes longer to process information. As we're going to be discussing in a few minutes, mild cognitive impairment represents a condition in between normal aging and dementia, in which a person may have noticeable problems with memory loss or other core brain functions, but these impairments are typically not sufficient enough to interfere with the activities of daily living. And that's really the key to everything, is the interference of activities of daily living. And there's two activities of daily living that we talk about. You have your instructional activities of daily living, which is paying your bills, going to the grocery store, being social, doing your laundry. Those are your instrumental, not instructional, instrumental activities of daily living. And then your ADLs, your activities of daily living, is more like your personal grooming and feeding and things like that. What you do need to know about this, and we'll go over each one's individually, is mild cognitive impairment may be a precursor to dementia, but 1 in 9 people with mild cognitive impairment will advance to dementia. So not everybody does. Dementia itself encompasses a range of neurodegenerative brain disorders, and people living with dementia have severe enough mental decline where it interferes with their activities of daily living. Finally, these changes can lead to functional impairments in basic or instrumental activities of daily living. So it's important to note that aging individuals who self-report memory loss do not necessarily have dementia. Instead, the person may experiencing slower processing capabilities associated with normal aging or impairment caused by a variety of treatable conditions. And we'll talk about those. Also, visual impairments may be associated with neurodegenerative disorders, but again, they're common in older adults. I'm an older adult, and so I have that slower processing. Someone will ask me a question, and it may take me, if I don't have the information right up front in my brain, it may take me a little bit longer to process that. One neurologist explained it to me this way a long time ago, and I've always remembered this. He said, think of your brain as a file cabinet. And every time you learn something new, you put it in your file cabinet, which is your brain. And when you need to access that particular file, you pull it out. But at our age, when we're an older adult, those file cabinets are pretty full. And so we don't just sort through 1 or 2 files in our brain. We have to sort through many, and they may not be in the right order. So it may take us a while to process that. Just kind of keep that visual in it. Think about, I don't know if you remember the game, I'm Not Smarter Than a Fifth Grader. And if you think about that TV program, it's where they challenge a fifth grader and an older adult to some questions, history questions, math questions, social studies questions. And almost 99% of the time, the fifth grader won, and the older adult, or the adult even, doesn't have to be older, would have to announce after he lost, I'm not smarter than a fifth grader. Think about that file cabinet. And for a fifth grader, it's important that they know, because they're learning this information, it's stored up front in their brain. So they're learning this information, and it might be, you have to identify the capital of every state. Okay, so it's in their file cabinet. They pluck it right out. For you and I, do I need to know the capital of every state for my everyday living? No, absolutely not. It's in my file cabinet. I may not even be able to retrieve it without going to Google or Second Brain. But if we do, it's going to take us a while to retrieve that. So keep that in mind. And so when we look at normal aging versus mild cognitive impairment versus dementia, there's going to be some differences. So again, normal aging, our body just slows down, our intelligence remains stable. We may forget maybe someone's name and have to rethink about it for a while. But a person with mild cognitive impairment may have significant problems with memory or other core functions. But impairments are not significant enough to interfere with daily life. They may be able to live independently, but they may need to sit down with a family member and maybe help with the daily bills. Or they may have to write themselves a note if they're meeting a friend for lunch. I know I have sticky notes and I put them on my kitchen cabinet. If there's something that I need to remember, or I put it in my phone. So we all learn our own little tricks on how to remember things. But with mild cognitive impairment, it's a little more significant. Dementia is actually a neurodegenerative brain disorder, and people living with dementia have severe enough, and I just want to qualify this acronym here, and this is people living with dementia. It's really hard, it's long to write, so they've chosen, and the reason, I'm going to go off topic for a minute, the reason why people in older adult care, working with people living with dementia, chose this as how to address people who have dementia, is because you don't want, I mean, you don't say that diabetic over there. You say that person has diabetes or that person lives with diabetes. So in our arena, we don't want dementia to actually define that person. So that's why we use this, people living with dementia. But they have severe enough mental decline so it interferes with daily life. And we look at some factors, and they're considered in a differential diagnosis between natural aging and dementia. So what's the difference between normal aging versus dementia? We first have the suspicion and recognition of dementia versus normal aging, and they're really founded on changes that occur across the following capacities. Cognitive function, and cognitive function is really thinking, and we need to think for everything that we do. Think of your brain as a cogwheel, and we have emotion, we have our senses, we have physical activity, but that's all driven by how we think, or what we call our cognitive function. Also, there's changes in memory, executive function, and information process. Now, again, we may forget someone's name, or we may forget where we put our keys. I don't know how many times a day, and some of you might giggle about this, but how many times a day I put my glasses down and then I go to try to find my glasses. I have to tell you, the other day, because I always keep a set at my desk here now, because I tend to walk around and take them off because I don't need them all the time. And my husband came home from work, and I had one pair of glasses on my nose and another pair of glasses on top of my head. And I don't know when during the day I did that, but do I have dementia? No, I'm just busy with work. I was looking for my glasses, couldn't find them, and I popped another pair on. So, people do this with their cell phones. This is normal. Executive function is decision making. And decision making can be anything from, it's going to be 80 degrees today, so I'm not going to wear my winter coat, to making a decision when someone calls you on the phone and says, I need $500 from your account because your grandson called and said he's injured and needs your help. And that's called a scam. And that's why a lot of people, older adults, get taken into those scams, is because they don't have an astute executive function to think and process that through. And there's that information processing that might say, well, this person doesn't really know my grandson. They don't think enough to ask more questions that would give them more information that only maybe you as a grandparent would know. So, they're making decisions based on not a lot of facts. There's changes in our visual function, which is normal to begin with. And that might be due to cataracts or glaucoma or just aging. But visual function also is processed in the brain. So when we talk about visual function, we're also talking about a change in what we call visual fields. We may have someone who may see something that's a little different than what it really is, because their eyes with dementia are not processing it correctly. And you'll see other sensory changes in hearing. Some people feel a change in how they perceive pain. Language skills. If someone's twirling their hand around up in the air and says that thingamajig over there, when you think they might be talking about a refrigerator, that's a little different than saying, I know I put my food in there, I know that it's cold, I know, and oh wait, it's a refrigerator. So there's a difference in language skills. And then again, like I said, the ability to perform independent or instrumental activities of daily living, driving, feeding yourself, going grocery shopping, doing your laundry. And then your ADLs, which is bathing yourself, washing your hair, brushing your teeth, getting in and out of the bathtub, things like that. And then there is some recognition of certain behavioral and psychological symptoms. People who are normal and healthy and aging usually don't have hallucinations. However, and we're going to talk about the different types of dementia because it's really an umbrella term. There are certain incidences where a normal, healthy person may have an episode of hallucinations or sensory changes, but it's related to something that's fixable, if that makes sense. So normal aging, a general slowing of cognitive execution, a decline in mental flexibility. You may have some struggles finding the right word, like I just used the refrigerator as an example. A slight decrease in short-term memory, intact for current events, and independent in both their IADLs and their ADLs. And they hold verbal ability and vocabulary. And I want to go back to, they may have a slight decrease in short-term memory, but their long-term memory is usually pretty intact. Normal aging, you'll see changes in the perceptual system or the speed and processing. And so they can perform those ADLs and those IDLs by themselves. They might have an inability, or you might start to see an inability to manage finances. That may be one of the earlier signs of those instrumental or independent activities of daily living, which can be suggestive of dementia. My mother had Alzheimer's disease. She lived independently. She ran a business till she was 84. And but what we noticed was her mail was piling up, and we noticed that her bills were not being paid. And so once we took a look at that, and then we started putting the pieces of the puzzle together, she was becoming less social. She didn't feel like, well, we felt she didn't feel like cleaning the house or doing her own laundry. But those are all processes, and we start to lose some of the processes that take a little bit of executive functioning. Where do I put the laundry detergent? What's considered dirty? So those are all things that that she stopped doing. And at first, you know, because no one wants to admit that their family member has dementia. So at first we thought, is she just giving up on life? She doesn't want to do this anymore. But when we saw the bills change, then we knew that there was something we needed to be evaluated. So there's going to be changes in all of these in your visual spatial. You may go to sit on a chair thinking that it's closer to you than what it is, and you'll end up on the floor. That's why, you know, when when I teach people in dementia care how to sit in a chair, I always tell them, the caregivers, to have the person back up and feel the chair on the back of your legs before you sit down. And anybody should do that anyways, because you never know when someone's going to pull the chair out from you. And you'll end up on the floor and hurting yourself at this point in our lives. So, but a lot of that can be explained by our visual spatial difficulties. You may have auditory problems, which are pretty normal at this age of life. So auditory meaning hearing sounds that aren't really there. Some speech and language impairments. We will see change in taste and smell. They've done some studies on this, and they find that people who lose their sense of smell earlier than normal as an older adult may be a precursor to Alzheimer's disease. They say that's one of those first things that that is significant. And many times people overlook that because they think, oh, I'm just getting old. You know, my sinuses, they kind of explain that away. But if you talk to people, there's a large group of people who have Alzheimer's disease that there was a change of smell before they actually were diagnosed. Same with taste. So mild cognitive impairment is one of the most common clinical manifestations of older adults, as compared to the dementias we'll talk about in a minute. you need to know, like I said, 1 in 9 people, older adults, will go from mild cognitive impairment into dementia. And mild cognitive impairment is usually marked with problems with, again, memory, language, judgment, thinking, problems greater than expected for the age of that person. So we talked about normal, and we know that there's slower processing, but usually you can make your own decisions that are safe and keep you healthy. But we might see a change in that usually with mild cognitive impairment, although they can still carry out everyday activities. And again, symptoms may be noticeable by family or friends. And at this point, if it's just diagnosed as mild cognitive impairment, most people can live independently in their homes with maybe some support, whether it's helping them make their meals, it might be med reminders, it might be reminders on the back door as they're walking out to use their walker. So there's different ways that people with mild cognitive impairment can live pretty happy lives. And like I said, not all progresses to dementia. However, when it does progress to dementia, it can progress to any of the Alzheimer's disease related dementias, which would be Alzheimer's disease, Parkinson's, frontal temporal degeneration or dementia, or vascular dementia. From a clinical perspective, it's most likely first detected in primary care, which means your primary care physician is the one that may detect it, although the symptoms may be overlooked and minimized because a lot of times people with mild cognitive impairment often know that there's something changing, and they kind of fake it till they make it. And so that's one thing that the primary care physician may not catch up on. It might be a new primary care physician and he doesn't know that person very well. But I was just working on a program about ethics and what we call capacity in healthcare, having someone with dementia be able to make their own decisions. And they said the best person to look at capacity, which means your autonomy and making your own decisions, would be your primary care physician. They're usually the first one. That's why Medicare wants us to go for that physical exam once a year. So there's a connection between mild cognitive impairment and depression. Depressive symptoms occur in about 63% of people with mild cognitive impairment. And they may hasten that conversion from mild cognitive impairment to Alzheimer's disease. We know that depression, with or without mild cognitive impairment, but depression has a significant bearing on whether a person will have Alzheimer's disease in their older life. And in my next little box there, it just says history of depression, especially early onset depression, increases the risk of developing Alzheimer's disease in the older adult. However, we know that research says that effective management of depression may be able to, a possible intervention target for MCI and possibly dementia. So what they're saying there is if we can treat that person early on and they stay on their medications, they stay with their therapist, that we may be able to abate the onset of mild cognitive impairment and then moving on to Alzheimer's disease. So what is dementia? Dementia is not a specific disease. It is a descriptive term for a collection of symptoms that can be caused by a number of disorders that affect the brain. There's really anywhere between 50 and 100 neurodegenerative disorders, and dementia is kind of the umbrella term for all of those. We're going to talk about a couple of the leaders in dementia today, but know that there's between 50 and 100. People with dementia has significantly impaired intellectual functioning that interferes with normal activities and relationships. They also lose their ability to solve problems and maintain emotional control. And they may experience personality changes, behavioral problems, such as agitation, delusions, and hallucinations. I'm sorry. While memory loss is common, memory loss itself does not mean that a person has dementia. Doctors diagnose dementia only if two or more brain function, such as memory and language skills, are significantly impaired without a loss of consciousness. So, as I said, dementia is an umbrella term. It encompasses a range of neurological degenerative diseases that cause progressive change in cognition, along with some behavioral impairments affecting your activities of daily life. They are chronic and persistent. It is a terminal diagnosis with no known cure. It's caused by brain damage to the brain. Type of dementia and symptoms really depend on which region of the brain is damaged. Our brain has 4 lobes. Each lobe does a different thing for us. But anything that we say, we do, we think, our emotions, our actions, our emotions, our behavior, everything that we do is controlled by our brain. And once that brain starts changing, that's when we start looking at dementia, because we know dementia is not a normal part of aging. However, we know that some symptoms of dementia can be short-term and are caused by treatable conditions. So the word dementia, again, is an umbrella term. And some of the main diseases is vascular dementia, dementia with Lewy bodies, Alzheimer's disease, frontal temporal dementia, and then there's the other rare diseases such as Korsakoff-Wernicke syndrome and Huntington's disease. Those are all considered neurodegenerative diseases, and they're all caused by different things. For example, Wernicke-Korsakoff disease is caused by chronic alcoholism, and Huntington disease is a recessive gene. So, once we get past these couple, they each have different explanations for what causes the changes in the brain. So now we're going to talk about our brain lobes. And we have the frontal here, the temporal or the temporal, right by our temples. That's why it's called that. The parietal lobe is right up here on the kind of the top back of the brain. And then all the way to the back is the occipital. Then we have the cerebellum and then the brain stem. And we'll talk about each one of those. So let's talk about Alzheimer's disease. I guess in this one, let me just say that I'm going to go back to this because it really doesn't give you any of your function. But let me just tell you that here is your processing, your cognitive thinking. It is also emotions. This is emotion and cognitive thinking and memory. Memory is in here somewhere. This is some movement and eyes. This is more movement. These are down here in the brainstem. This is balance down here and has some spatial, where you, so again, depends on, if you had a head injury or if you have Alzheimer's disease or another type of dementia, it depends on where that disease is changing the brain. That will change, you'll see changes in the person. So Alzheimer's disease, most common form of dementia. It is accounts for 60 to 80% of the cases. Starting at 65, the risk of developing Alzheimer's disease doubles every 5 years. By 85 plus, the risk is nearly 50%. By 2050, the number is expected to more than double due to the aging population. And it affects approximately 200 to 250,000 people younger than 65. So with Alzheimer's disease, if you are diagnosed 65 or younger, it's usually called early onset, which has a different length of the course of the disease. It is the 6th leading cause of all deaths in the United States. and it is the 5th leading cause of death for people over 65. Time from diagnosis to death can be as little as 3 to 4 years if the person is greater than 80, but as long as 10 years in younger people. And then I'm going to go back to that early onset, and that's usually about 8 years. So if you're very young when you're diagnosed, or if you're over 80, you're going to have a shorter lifespan. What changes the brain is this amyloid plaque and neurofibrillary tangles. What they are finding out now on autopsies is that there are people that were cognitively intact. Most of them were people who use their brains a lot, scientists, authors, people who were always thinking, also had these amyloid and neurofibrillary tangles, but it didn't seem to affect them. But on most people, once you start having changes and you start developing these plaques and tangles, which are really large protein fragments that actually tangle onto the brain cell, and it causes a lack of oxygen to the brain cell. You see brain inflammation, you see a release of free radicals, and you see a shrinkage of brain. That's really the pathology, is these amyloid plaques and neurofibrillary tangles. I just heard last week that it hasn't been approved yet, but there is a blood test that they can see if you have plaques and tangles in your brain. However, what it doesn't tell us is that, are you having cognitive changes? Do you have Alzheimer's disease? That can only still be diagnosed on a postmortem. You can look at the changes in the brain, you can see the changes in the brain in a PET scan or an MRI, but you can't really diagnose until you look at those plaques and tangles under a microscope. Because what we do now know is some people live with plaques and tangles, and almost everybody's going to have them, but it's the people that have a large amount of them, if that makes sense. This is just an example of a drawing of a normal brain on the left side of your screen. I'm sorry, this is not the normal brain on the left side of your screen, but what you'll see on the right side of your screen is the ventricles get larger and they fill with cerebral spinal fluid. You can see down here how much bigger it is than on the normal brain. This is your hippocampus, and so this must be the temporal lobe or the frontal lobe, and that's what stores all your memories. So you can see this is starting to encroach on that. So this person at some point, once it gets to about here, is going to see some memory loss. Alzheimer's disease has a long, straight decline. They get diagnosed, and for many people, the diagnosis is several years before they actually start to see significant changes. For example, we saw some changes in my mother that we kind of were able to explain away for a while, but as they became more frequent and things were more evident, was when we took her to the doctor to have her evaluated. And then you see a steady decline from there, which is over about 10 years. Some of the risks, so these are things that you can take care of sometimes, not all of them, but sometimes. If you have high blood pressure, keep it regulated, keep it, on the normal side. If you have high cholesterol, do what you can to get that cholesterol down. That's hyperlipidemia. Diabetes, because it changes our vascular system. So does cardiovascular disease. So does smoking. So does obesity. Age also has an impact. We know that, we just said, it doubles after the age of 80. And then gender, more females are susceptible to Alzheimer's disease than males. Why is that? We don't really know for sure yet, but what we think is because women live longer. Men smoke more than women at some point, but that's not always true. If there's a diagnosis of Alzheimer's disease, in the family, that puts you at risk. So since I had a mother that has Alzheimer's disease, these are the things that I need to control. If you've had head trauma, so we're looking at, our football players, and they're having some significant dementia and cognitive impairment from the closed head injuries that they experienced during football, same as our veterans. And then Down syndrome, they have about a 70% higher rate of Alzheimer's disease than someone who does not have. The next one is that we're going to talk about is vascular dementia, and that's caused by blockage or damage to the brain's vascular system. And that can be by strokes, trans-ischemic accidents, which we call the mini strokes, vascular disease, diabetes, anything that changes the vascular system in the brain. The speed of progression is going to vary from person to person, depending on what their vascular risk factors are and how many little mini strokes they have. Because every time you have a little mini stroke, it's going to cause another insult in that brain. The progress may be in steps. So you may, and I think I have it on my next. So you may get the diagnosis, then you'll see the decline here. Then they are stable for a while. Then they have another vascular accident, or what we call a vascular insult, and then they're stable again until the end of their disease. So again, this is terminal as well. It's also seen in tandem with Alzheimer's disease, and I think the reason for that is a lot of the risk factors with Alzheimer's disease, and we'll go back to that, hypertension, cholesterol, diabetes, cardiovascular disease, smoking, and obesity are all things that change your vascular system. So it makes sense to think that you could have Alzheimer's disease and how do we tell the difference between them? And it might be those little vascular accidents. I say that my mom had Alzheimer's disease, but if I look, she had a lot of these, she had a lot of the risk factors. So I was sitting there one day talking to her when she had a little TIA, and it was just like she kind of zoned out for a minute and wasn't aware of her surroundings, and then came right back, but again took her a while to get re-engaged in the conversation. And there's not a whole lot that you can do about those. So the lifespan of people with vascular dementia is usually 3 to 5 years after the symptoms begin. So again, here's our risk, our lifestyle risks: lack of physical activity and exercise, a lack of social support. Why do they say lack of social support? Is because people with good social rapport tend not to eat as unhealthy, tend not to smoke as much, tend not to have the obesity, because they usually have a significant other pounding them to get healthier. That's not always the case, but sometimes that is what happens. Common symptoms of vascular dementia is memory loss, hallucinations, some inappropriate behavior. We'll see changes in personality, difficulty in organizing their thoughts. You'll see a change in language skills. They'll misplace things, and then poor judgment. So here's your executive function. And those are common symptoms of vascular dementia. Let's talk a little bit about LBD, which is Lewy body disease, and Parkinson's disease dementia, because oftentimes they go hand in hand. You can have Parkinson's disease on its own, or you can have Lewy body's disease and Lewy body dementias. The defining features of Lewy body disease include motor Parkinsonian, and cognitive impairments. The timing of the dementia onset for dementia with Lewy bodies and Parkinson's disease dementia distinguishes them. The diagnosis of Lewy body disease dementia is challenging. and they both may have some genetic similarities. The location of the Lewy bodies. So this is another disease where you're going to see changes in the brain, and the changes are called Lewy bodies, and this is what they look like. They're similar to the plaques and tangles, but they show up in this Parkinson's disease dementia. And why is it called Lewy body? Why is it called Parkinson's? Because these are the doctors that discovered them. If you discover anything, if I discovered these plaques that are seen in Lewy bodies, it would be Petrik body dementia. So that's how they name things in healthcare. The reason why it's very hard to diagnose Lewy body is because the progression has its upswings, and they can be going down, having a bad day. Next day they'll be doing good, they'll plateau, they'll drop a little bit, they'll plateau, and they'll drop some more. And then they head down more, they go up a little bit, and this repeats itself until the end of the disease. So dementia with Lewy bodies is a result of the Lewy bodies in the cortex of the brain. And again, Lewy body is just a type of protein. It is the third most common form of dementia. And again, because of its fluctuation, it's difficult to diagnose, but we do see changes in thinking and reasoning. There's confusion and alertness that vacillate every day. We will see slowness in gait imbalances, gait is walking, other Parkinsonian movement features. These people will have well-formed hallucinations and delusions. They'll have trouble interpreting their visual information. They also have sleep disturbances, and they're doing studies on people who are having sleep disturbances in their younger lives and tracking them through aging to see if the sleep disturbances is one of the precursors to dementia with Lewy bodies. So we don't talk about sleep a lot in dementia care, but it's really important for us to get a good balanced sleep cycle every night. They'll have some memory loss, but it's not as significant as Alzheimer's disease with Lewy body dementia. So 1.3 million people in the United States have Lewy bodies dementia. There is a high number of undiagnosed and frequently misdiagnosed cases. Excuse me, I saw my uncle at a wedding this weekend, and he's 90 years old. He's been pretty spry and still cognitively intact, although he's not as verbal. He's more on the quiet side now, where he used to lead the conversation. Some of that might be due to his deafness. He does wear hearing aids, and they're never 100% perfect, especially in a crowd. But I noticed when he got up, he shuffled and he hesitated. And so I said to my cousin, next time he goes to the doctor, you may want to have them address Parkinson's, because she was like, do you think? And I said, it could be because I see the shuffling in his gait. He would walk a few steps and then he'd stop, and then he'd kind of, move back and forth, trying to get the momentum to move a few steps further. And I've not seen this in him before. It may be a little late for diagnosis of Parkinson's disease, but it totally could be the case. Signs and symptoms are changes in thinking and reasoning, confusion, alertness that vary from time to time during the day to the next day. You'll see slowness, gait imbalances, and other Parkinsonian movements, which is usually tremors of the hand. And there's something that we call pill rolling in healthcare, and that's when they take their index finger and their thumb and they roll it together, and we call that pill rolling. And if you see someone pill rolling, it's pretty significant for Parkinson's. We were in church one Sunday, and our chief of police, who had just retired, was in front of us. And when he turned around to do the handshake of peace, I could see he was pill rolling. And we got out of church, and I said, I think Dan has Parkinson's, because you could see the pill rolling that he was doing. So that's a significant sign. I'm not a diagnostician. I don't know if he does, but that my nursing brain was kicking in. You will see well-formed visual hallucinations and delusions. And when we talk about living in someone's world, this is important here to do that, because what they're seeing and what they're hearing is actually what they're seeing and hearing. And by telling them there's not a, cute little poodle sitting at their feet is only going to frustrate them and agitate them. So you need to get into their life. And you can say, what color is that dog? Does that dog belong to anybody? Sure is a cute dog. And then kind of redirect them. You want to have a drink of water or a nice cup of iced tea with me? Let's go ahead and go over there to the table. So that's a form of what we call redirecting. But you live in their world, because if you said, John, that is not a poodle, there's no poodle in this room, they're seeing it, and their delusion is their reality. Because they do have trouble interpreting this visual information. We already talked about the sleep disturbances. Sometimes the sleep disturbances are so significant that the partner who's living with them has to move beds, because there's a lot of thrashing around. They can have violent behavior while they're sleeping. And so the partner sometimes will have a lack of sleep, and so they end up moving to the other bedroom. There is no medical test that diagnoses Lewy body dementia specifically. It's really based on the patient's history, their physical and psychological exam. They may do brain scans on them. The diagnoses are really most probable. They only get, they're only accurate about 90% of the time. And there are neurologists who specialize in this particular neurodegenerative disease. And if you have one in your area, you're really lucky, because those are the ones that really get focused on it and are able to diagnose them. So what's the difference between Alzheimer's disease and Lewy body? It's really the memory loss and the movement. Memory loss is more prevalent in Alzheimer's disease, and it may cause memory problems, judgment, planning, and visual perception, while movement is really the key to Lewy body dementia. So you'll see problems with walking, balance, and getting around. And they may have some memory loss later on in the disease, but not significant and early. Excuse me. Also, the difference between Alzheimer's and Lewy body dementia is you'll see hallucinations, delusions, and misidentification more frequent in Lewy body than you see in Alzheimer's disease. Delusions, hallucinations for people with Alzheimer's usually don't show up until late mid-stage Alzheimer's disease, and they're usually associated with sundowning, visual distortions, and also urinary tract infections or any type of infection in the body that changes the metabolism. But REM sleep disorders is very common in Lewy body dementia. And then disruption of the autonomic nervous system for people with Lewy body is more common. Now, the autonomic nervous system is something that regulates our blood pressure, it regulates our secretions, it regulates our urinary tract and our gut. So you'll see more incontinence, you'll see more constipation, you'll see more changes in respirations and drops in blood pressure. Excuse me, with Lewy body. So frontal temporal is another more common. It usually affects people younger than 60 years of age. It's the second most common of the early onset after Alzheimer's disease. They're usually diagnosed between 45 and 64 years old. So that's a pretty young. And we see about 50 to 60,000 Americans are diagnosed annually. Because of where it is in the frontal temporal part, you're going to see changes in personality, loss of inhibitions, and problems with language. So, you're going to see changes in behavior. And as a very exaggerated example, you might have a wonderful grandmother who starts shoplifting, who never did that before, because there's really a loss of inhibitions, but really your loss of executive function. The imaging may show tau and some of the other proteins, but again, you're going to see they really on a postmortem what you're seeing. And like Alzheimer's disease, this has a steady decline. It doesn't vacillate at all. That's caused by progressive damage to both the frontal and the temporal area, which is why we call it frontal temporal. Again, the onset is 45 to 60. There are some different variants that cause change in personality, behaviors, conduct, judgment, and empathy. There's one thing called primary progressive aphasia, which causes difficulty in speaking, writing, and understanding language. And this is where, although they have not said that he has frontal temporal or frontal lobal degeneration, this is where our actor Bruce Willis is at. He has primary progressive aphasia. So they don't want to come out and say he has FTD, but if he's experiencing this, it's probably what's happening. You see some progressive supernuclear palsy. So you'll see them kind of have an imbalance walking. And because they do, they fall a lot. Because their balance is changed, the same as Parkinson's, usually their first diagnosis is Parkinson's. Kind of an offshoot of that is ALS. We know that Lou Gehrig had ALS, so we know that that's a progressive loss of all voluntary muscle movements. And again, that's a steady decline. So these are the three different variants: the progressive, where they have behavior problems, where they have the language, which is, like I said, where Bruce Willis is, and then motor decline, which is, the ALS, or something we call supernuclear palsy. These are just some of the variants. And again, they each have their own challenge, but there are different offshoots of frontal temporal dementia, and they're called the variants. So some of the symptoms or manifestations of those variants are categorized with behavior, verbal, understanding, written, movement, falling, body stiffness, changes in behavior and language. And these are just some of our risk factors. Usually there's for about 40%, there's a familial history. You may see an autosomal pattern. So it is important, if you're diagnosed with this, to have a family meeting and talk about it. It may be worthy getting tested. These people have something called disinhibition. So, it would be nothing for them to maybe urinate in a plant. They may say something sexual or attempt something sexual with someone else. They may steal. They may be apathetic. So you see those changes in personality. They also may have a blunting effect in apathy, like they don't care. And then sometimes you'll see those highs, which is euphoria. It's typical for them to isolate. And on those early stages, they have very little memory impairment. Oftentimes these people will binge eat, so we see a lot of weight gain with these people. So for some people, they've had to lock their refrigerators because people are overeating, and then we will see a few psychotic features, but not very often. So real briefly, let's talk about communicating with people with dementia. In our normal communication, we have a receiver and a sender. We have a message, and the message here is, I think I want to order a pizza. And then the receiver says, so the sender says, I want to order a pizza. Do you want some? And the receiver says, yeah, that sounds like a good idea. I'm really hungry. So we shared information, we shared thoughts, and we shared feelings. Simple. However, when someone living with dementia, there is no longer a shared responsibility. So, because this person has changes in their brain, they can't communicate effectively. So what we want to do with communication, excuse me, is to share a moment, provide an opportunity for a person to be successful. That's really what we want to do, is keep their personhood and their dignity intact through that conversation or any type of instructions that we're giving them. So in early stage, they may have difficulty with word finding. They may use words with less meaning. They may have difficulty with abstract thought, which is why paying the bills is difficult, because it's math. They may repeat the same question. They may digress or become less social. They may not talk on the phone as much. Talking on the phone is kind of a complex process. You have to pick it up, you have to dial it or answer it if it's ringing. Then you talk into a little speaker, and we lose the concept of that. They also have comprehension problems and awareness of difficulty. Difficulty with awareness. I'm sorry. So what do we want to do? We want to repeat our messages, use memory aids, sticky notes. You want to provide information. Don't tell them that they have a doctor's appointment in 2 weeks, because they'll either forget, or in order not to forget, they'll ask, what do we have to do on Friday? What was that we have to do? And they'll ask you every day. So provide the information close to the time. Give them an opportunity to express their feelings. I'm not real happy about going to the doctor because they're going to check me again for my brain. Use questions to stimulate conversations and involvement. So why does that make you nervous about looking at your brain? So structure those conversations. Here's the big thing on any of the stages of communication, is allowing enough time to answer. You tell them something, it's got to process in their brain. And remember, if they have dementia, their processing is slow. So 15 seconds, count out 15 seconds to yourself. It's a pretty long time, but that's how long it typically takes for someone, at least in middle stage dementia, to communicate something back to you and process what you said. So we just say for any time in dementia, 15 seconds would be good. Mid-stage, they're losing their train of thought. They are having more difficulty with comprehension. They're going to substitute or use wrong words. They're going to increase repetition. They're going to start avoiding social situations and will have difficulty initiating conversation. So again, for middle stage, we want to keep our moods relaxed and calm. Use touch when appropriate. If they're angry, I would put my hand out without touching them. If they touch your hand, if they grab your hand, that means that touch is fine. But think about when you're angry and someone touches you, get your hand off me, I'm mad at you, right? So that doesn't go away with dementia. So make sure it's appropriate. Get the person's attention before speaking by calling them by name. Watch the tone of your voice, and also watch the tone of their voice. The tone of your voice is going to set the setting, so to speak. But watch the tone of their voice. Are they angry? Are they apprehensive? Are they yelling? Are they soft-spoken? Make sure that there's not a lot of noise in the room so they can concentrate and you can hear what they say. Speak on eye level. Don't stand above them. That's a demonstrative pose, and it's very threatening. That's watching your body language, and watch the body language of the resident. Are they wringing their hands? Are they rubbing their legs? If they're doing that, they're anxious. They're going to respond more with emotion than what the words are. So look at their body language, and then again, slow down the pace of communication. Lastly, things to avoid: confrontation, domination, rigidity, talking to them like a baby, quizzing them, insensitivity, and arguing. Don't argue. You cannot argue with a person with dementia. They don't understand what is right and what is wrong. I know we're running a little bit over, but let's talk a few seconds on delusions and hallucinations, and the difference between them. Hallucination is a false perception. Usually sensory delusion is seeing or smelling or tasting something, and paranoia is being suspicious of someone. Not all hallucinations are frightening. Remember, I said someone had a little poodle sitting at his, so you kind of have to pick your battles with this one. If they're feeling anxious about it, what you want to say is, I'm here to protect you. You're safe. That bad person's not gonna get you. Always make sure that they can see and hear well, kind of look at the situation, see what's upsetting them. Are they doing something dangerous? If they are, you need to respond with caution and then react calmly and reassure with words. Look for the feelings that are really behind the delusion or the hallucination. This must make you anxious. You must be scared. I know that you're seeing something I don't see, but I get it. And then redirect them and modify the environment if necessary. Turn the lights on, remove the dress that's hanging on the closet door that may look like a ghost to them. And you're not going to say, oh, it was just a dress. You're saying, just say, oh, I got rid of that for you. So again, you're not going to argue with them. And that really kind of wraps it up. Any questions or concerns we have at the end here? I'll give it back to Barb.
Any questions you want to put into the chat about any of the material today? Thank you very much. Covered a lot. There's a lot of information here, and oftentimes, gets very confusing to describe the different kinds of dementia and so forth. And I hope that you're clearer today after, learning some of this from Chris. So again, if you look in the chat, you're going to see there are no copies of the slideshow that are distributed to anyone. They're property of Elderwerks. So there's a question about differentiating between frontal lobe and Lewy body, a differentiation between BHV frontal lobe and Lewy body. Chris?
Pardon? I'm sorry.
You have a question in the chat.
Oh, I'm sorry.
Yes. How can you differentiate between BHV frontal lobe and Lewy body?
It's really different. It's difficult to differentiate between those two. And it's really just looking at the actions of the person and looking at and again, sometimes if the person agrees or the family agrees to do a postmortem, you'll see the Lewy bodies there. You can see some changes in the brain, but not all of them. So it's usually just on symptoms.
Chris, I have a question because there's so many people. We, for recording to the state and everything that we do to create this material, this is property of Elderwerks. We don't distribute these slides. So when you take the class, it's taking notes, it's taking screenshots. Chris, does the office have a bird's eye view at all of any of the basics to send to our audience, or do we not do that?
They don't, but anything that's recorded, you can get on our YouTube site and view any of these.
But the CEs are not on YouTube.
Oh, they're not?
No.
I thought they were.
No,
okay.
You're never on YouTube.
No.
Only the community events.
I can send out notes, but that's about it.
Okay. Should the patient's doctor be able to refer to experts?
Absolutely, they should. I was just talking to someone and they're still going to their primary. And I asked them about seeing a neurologist or a neuropsychologist, and they don't have either in their immediate area. That's the problem, is that a lot of times, healthcare has changed over the year. And while many of these specialties, there was a plethora of them years ago because of all the changes in corporations and because of all the insurance and the malpractice, a lot of people have stopped practicing. And so it's, or aged out, and the younger population is not getting into it, but they should. And I would consider them a very good doctor, um, uh, because, especially if they are a primary who hasn't had a history. I mean, I've been going to my primary for almost 25 years. So just by the questions I ask and looking at me, he can pretty much tell whether I'm still cognitively intact. So he may not ask me to say remember 3 things or count back from 100, which are typical things primary doctors will do to assess for intact cognition. But if I had an episode, and it's called global amnesia, a couple years ago, and I went right to he referred me right to the neurologist. So a good doctor will refer you out. They may not be able to handle it. So, and you
Somebody wrote, I know a case where the nearest expert is out of town. Patient won't travel. He also refuses to go into a quote unquote home, which is a senior living situation. He has a live-in caregiver of sorts. Yeah.
I know.
So as we exit this webinar today, you will see an evaluation to fill out. And if there's any issue, you see I sent to everyone help at Elderwerks, ELDERWERKS.org. If you have an issue getting the eval, your certificate will then be sent to you after that. So as soon as we exit the webinar, please wait and you'll see the evaluation. I want to thank everybody for their time, for staying till 10 after. Much appreciated. Thank you for all your good questions and thoughts. And everybody have a wonderful day.
Thanks, everyone. Enjoy the day.